Okay, good afternoon.
Good afternoon, doctor.
Okay. So this is our session on cardiovascular disease in pregnancy, and later on we will have pulmonary disease in pregnancy. Okay, both would be based on the 26th edition of your Williams Obstetrics. Okay, this is in no way um, a substitute for you reading your Williams book, but we would try to summarize what is inside so that you would have a chance to do focused studying for your in-depth analysis for the topic. Okay. So what is the epidemiology of cardiovascular disease in pregnancy? So it is related to 1/4 of all pregnancy-related mortalities. Okay. The prevalence of which is continuously increasing because of a lot of hypertension, diabetes, obesity, which are lifestyle diseases. More pregnant women are becoming pregnant at a later age. And technology, which allows women who previously would not fathom to get pregnant, desires to get pregnant even once. Hence, increase in pregnancy-related mortalities in relation to cardiac diseases. Now, again, before we tackle our abnormal cardiac pregnancy diseases, of course, we have to look back on what normal cardiac physiology would be. So, normal cardiac physiology, it's accepted that there is increased cardiac output by as much as 40%. Okay. At 8 weeks, this is due to increased stroke volume because there would be lowered vascular resistance. Okay. Mid-pregnancy, the increase would be due to the resting pulse and stroke volume because there's increased end diastolic ventricular volume from increased blood volume of pregnancy. So even if there's increased cardiac output, it is important to remember that the intrinsic left ventricular contractility will not change in the normal cardiac physiology. Cardiac dysfunction then occurs when there's ventricular dysfunction, leading to cardiogenic heart failure. And this happens, as we mentioned, mid-pregnancy because of that change at 28 weeks. So remember, in your history and physical examination, we really expect the heart, the blood pressure of a pregnant patient to increase by 28 weeks. And this is because there's pregnancy-induced hypervolemia and your cardiac output peaks during 28 weeks. And peripartum. So during near labor, this is where you experience your preeclampsia, hemorrhage, sepsis, and anemia because of the increase in cardiac burden these events or these situations bring about. Okay? So, ventricular function in pregnancy. So, ventricular mass and volumes increase. So, there's increased end systolic and end diastolic dimensions, but your septal thickness and ejection fraction should be unchanged. Okay, so your mass and volume increase, but the thickness and the ejection fraction would remain the same. So what does this mean? So this is brought about because there's remodeling. So this is what we call plasticity. So there's eccentric expansion of your left ventricular mass averaging 30 to 35% up to near term. Okay. And this is a spherical remodeling. So this makes what you are used in your normal heart ventricular functional graph by Braunwald less accurate for pregnant women with ventricular dysfunction. Because pregnancy would be a mixture of your eccentric and your concentric ventricular remodeling. Okay? So we've had concepts of ventricular mass and volume, unchanged septal thickness, and ejection fraction unchanged. Previously, we have change in cardiac output, but your left ventricular function remain unchanged. Okay. So how we diagnose heart disease? So this would be within the realms of normal. It's normal to hear functional systolic heart murmurs. It's normal to have increased respiratory effort. We see edema develop. We see fatigue and exercise intolerance develop. And identifying when these symptoms border on the heart disease during pregnancy, which is on your table on your right. This is a table from Williams. Progressive dyspnea or orthopnea, nocturnal cough, hemoptysis, syncope, chest pain, and findings of cyanosis, clubbing, persistent neck vein distension. Okay, systolic heart murmurs more than 3/6. Diastolic murmur, cardiomegaly, tachycardia or arrhythmia that's persistent, a split-second sound, a fourth heart sound, and of course, if you get the criteria for pulmonary hypertension. Okay. Still, within normal, we often see ECG changes and we interpret it as abnormal. But within certain limits, there's a reduction of your PR interval, a slight increase in your heart rate, a slight left axis deviation, inverted or flattened T waves. There's Q wave lead in lead T3. You also request for a chest x-ray. What's the expected? Because there's a gravid uterus, your diaphragm lifts up, your heart gets enlarged a bit. You also check for your 2D echo if there are heart problems. Okay. Chest x-ray, 2D echo. So normal, within still the realms of normal. There are small increase in dimensions of your chambers. This is mainly because, again, of your gravid uterus. There's a slight growth in your left ventricular mass, which is greater than your tricuspid and mitral valve regurgitation. And your MRI, although there's high reproducibility and less affected by ventricular geometry and body habitus, you can assess the right ventricle, look for congenital heart lesions, and myocarditis. Okay. Could also diagnose by exercise stress testing. So this is an objective assessment of one's maternal functional capacity. Diagnose exercise-induced arrhythmias through stress testing. So more advanced diagnostic studies would be your myocardial perfusion studies. You could also do your cardiac catheterization with limited fluoroscopy for more severe heart disease. Okay. So functional classification of heart disease. Be familiar with your New York Heart Association heart failure classification. So there is class 1, class 2, class 3, and class 4. Okay, the extremes, it's easy. Class 1, there's no limitation, no physical activity. There's ordinary physical activity and does not cause symptoms. So this is a normal heart. Okay. On the other side of the spectrum is your class 4. Severe limitation and discomfort with any physical activity, symptoms present even at rest. So that's also easy to quantify. You're doing nothing, yet you still have limitation and discomfort severely. So at the middle, you have to know how slight limitation of physical activity and marked limitation of physical activity would be defined. So class 2, comfortable at rest and ordinary physical activity causes symptoms. So for example, you are walking, you are climbing 2 flights of stairs, and it's causing symptoms. Class 2. Marked, less than ordinary activity causes symptoms. Or you just walk 1 meter. You just exerted a slight effort, then you're already out of breath. So that's marked limitation of physical activity. Okay? So New York Heart Association heart failure classification, you have 4. Class 1, class 2, class 3, and class 4. Okay, and this is important as we have your WHO risk assessment for cardiac disease and pregnancy. Okay, so we'll have your WH1. So it means morbidity or mortality risk would be no higher than your general population. So it's like that you don't have any cardiac disease. So it means you may have cardiac disease, but it is not significant to pregnancy morbidity or mortality. Okay. So what are these? So these are small or mild uncomplicated pulmonary stenosis, a patent ductus arteriosus, MVP, with no more than trivial mitral regurgitation. Okay. Or you have successfully repaired simple lesions, such as the following. You have a repaired ASD, you have a repaired VSD, you have a repaired PDA, you have a repaired total anomalous pulmonary venous drainage, or isolated ventricular extrasystoles and atrial ectopic beats. These are insignificant and would not risk any pregnancy morbidity or mortality. Okay, so what's done? So you just ask for a cardiology consult once or twice during pregnancy, and you could deliver in a local hospital. Okay, meaning a primary or a secondary hospital and not necessarily a tertiary hospital with all the services. So WHO2. So there's a small increase in risk, maternal mortality, and moderate increase in morbidity. So if some examples would be if your ASD or your VSD would be unoperated on, a repaired tetralogy of Fallot, any arrhythmia, and Turner syndrome without aortic dilation. Okay, recommended cardiological care would be a cardiology consult each trimester, could deliver in a local hospital. Okay. 2 or 3, there's an intermediate increase in maternal mortality risk and moderate to severe rise in morbidity risk. So what are the conditions? You have your mild left ventricular impairment, hypertrophic cardiomyopathy, a native or tissue disease not considered WHO 1 or 4, Marfan's without aortic dilation, a repaired coarctation, and a prior heart transplantation. Okay, so every other month, you do your cardiac consult and delivery should be at a referral hospital. Okay, so you will need more services for these patients, WHO 2 or 3. This one is WHO 3, significantly increased risk and severe increase in morbidity. So these are the conditions: mechanical valve, systemic right ventricle, post-Juantan operation, unrepaired cyanotic heart disease, other complex congenital heart disease, moderate left ventricular impairment, prior peripartum cardiomyopathy, moderate mitral stenosis, severe asymptomatic aortic stenosis, moderate aortic dilatation, ventricular tachycardia. Consultation is monthly or bi-monthly, care at a tertiary care hospital. Okay? And lastly, you have your WHO4, a very high risk of maternal mortality or severe morbidity. Pregnancy is contraindicated and termination, if allowed in your countries, discussed. So these are the conditions. You have your pulmonary arterial hypertension. You have your severe systemic ventricular dysfunction, and New York classification of 3 or 4, or a left ventricular ejection fraction of less than 30%. Prior peripartum cardiomyopathy with residuals, severe left heart obstruction, severe aortic dilation, severe coarct, and Fontan procedure with residual complication. Cardiac recommendation: pregnancy is contraindicated. But if pregnancy occurs, cardiology consultation would be monthly, and you're, of course, required to deliver in a tertiary care hospital. So you have your New York classification 1 to 4. You would also have your WHO risk assessment for cardiac disease and pregnancy 1 to 4. Okay? So we have to do preconceptional counseling for patients with cardiac disease. And the aim would be to optimize cardiac functions to mitigate pregnancy complications. Okay. Because, as you have seen in the WHO risk assessment, some cardiac conditions can be surgically corrected. Okay. Other reasons why: some cardiogenic drugs are teratogenic, and heart diseases are congenital, and you could pass it on to your offspring. Okay. As you will see on your table on your right, you have your congenital heart disease in your fetus and how much percent could your cardiac lesion be seen if your previous sibling is affected, if father is affected, or your mother is affected. Okay. So what are the risk factors for cardiac disease? If you will look at race, morbidity would be highest in African American women. Of course, there are other risk factors such as we have mentioned, such as age, hypertension, and obesity. Okay. Antepartum care, of course, would require a multidisciplinary approach. And of course, we have to prevent and recognize early symptoms of heart failure. Okay? We have to avoid infection, particularly bacterial endocarditis, by vaccinating pneumococcal and influenza vaccines. And of course, refrain from cigarette smoking and drug use, which will increase incidence of heart disease. For labor and delivery, assisted vaginal delivery is preferred. Okay, not normal vaginal delivery because we want to prolong the second stage of labor. So we either do a forceps extraction or a vacuum delivery. Cesarean is done for obstetrical indications. Okay, when would obstetrical indications appear? You have your usual monitoring of your cardiac disease patient. But this one recommended cesarean outright for the patients who exhibit the following. Okay, a dilated aortic root more than 4 centimeters or an aortic aneurysm, acute severe congestive heart failure, anyone who has had recent myocardial infarction, severe symptomatic aortic stenosis, and a need for emergency valve replacement immediately after delivery. And 6, warfarin administration within 2 weeks of delivery because of fetal risk for intracerebral hemorrhage because the fetal liver takes up to 2 weeks to metabolize warfarin. Okay, so there are 6 conditions wherein cesarean delivery is recommended outright. Okay, you will not wait for any obstetrical indications before you decide to do a cesarean section. Okay. Recommended analgesia and anesthesia. Of course, your goal is to relieve the pain from the patient from pain and apprehension because more pain would push the patient further into failure. So such that continuous epidural analgesia is recommended. Okay. So heart failure, 1/4 occurs intrapartum. Okay. This is due to your physiologic stress and fluid shifts during labor and delivery. Okay. That's secondary to your catecholamine release and your second stage Valsalva. So the most frequent cause of your heart failure in pregnancy would be your chronic hypertension with superimposed preeclampsia. Okay. Pulmonary edema should be treated with aggressive diuresis, and your tachycardia treated with your beta blocking agents. Okay. In the puerperium, fluid is mobilized into the intravascular component, and because there's a release of the fetus, there would be now reduced peripheral vascular resistance. Now all the blood is coming back to the system. And resistance displaces a higher demand on your myocardial performance. Okay. Thereby, so heart failure then could either be primarily structural or a functional cardiac disorder, which can lead to this clinical syndrome caused by impaired ventricular function. As you know, cardiac output changes, but in reality, your left ventricular function should not change. But if it's impaired and cannot adapt, then heart failure will occur over pregnancy. So some examples would be mitral stenosis, pulmonary hypertension, peripartum cardiomyopathy. Okay. What happens? There's chronic pressure overload leading to ventricular dilation and impaired function over time. And of course, your perinatal mortality rates would be high. So, what's the diagnosis? So usually, at the end of the second or beginning of the third trimester and peripartum. So that is your 28 weeks. So what would happen? The usual symptoms that we see listed in the table that I have mentioned, your dyspnea, your orthopnea, palpitations, cough, loss of functionality. Okay, clinically, you would see your RALs, you would see your hemoptysis, also in the table, progressive edema, tachypnea, and tachycardia. Okay, in the chest X-ray findings, you see cardiomegaly and pulmonary edema. Okay. Echocardiography, your 2D echo may show an ejection fraction of 2.7 centimeters per meter squared. Okay. Diastolic failure is also found depending on the underlying cause. And the cause of your ventricular dysfunction, such as your valvular abnormalities or concentric hypertrophy, may eventually become apparent. Okay. And how do we manage? You diurese to reduce preload. Of course, we don't diurese indiscriminately. Of course, we have to manage the fluid balance of the patient. Okay. It's imperative that we control hypertension to reduce afterload. Okay. What's the agent of choice for your pregnant patient? Your oral tablets would be your methyl-dopa, maximum dose of which would be 3 grams per day. You have your IV meds. You could give your hydralazine tablet. You have your Catapres or your Captopril. That's clonidine by generic name. Sorry for the brand name. Or you have your IV meds. You could use your hydralazine. I think in India, labetalol is available. So you could use that also, the beta blocker agents. Okay. What is not to be used? Your ACE inhibitors. They are avoided because of marked fetal effects. Okay. Beta blocking agents lower mortality rates. You could use digoxin, which provides inotropic support and lessens hospitalization. You could use prophylactic heparin, avoid thromboembolism. And more advanced technology, you have your left ventricular assist device or your extracorporeal membrane oxygenation or your ECMO. Okay. So for surgery-corrected heart disease, porcine tissue, mitral valves are safer during pregnancy because thrombosis is rare and anticoagulation is not required. However, bioprosthesis would be less durable than mechanical ones. And pregnancy accelerates the risk for bioprosthesis to be replaced. So it's a either or thing. So they're safer in pregnancy, but when you get pregnant, it makes the risk for you needing the replacement faster. Okay? Of course, your mechanical prosthesis would usually really last longer. Okay? So that is what we have to take into consideration for surgically corrected heart disease in pregnant patients. Of course, when we do surgical correction and put your valve prosthesis, you have to do your anticoagulation. And we know warfarin is the most effective anticoagulant for preventing thromboembolism, but it will cause your harmful fetal effects. Okay. The choice between the two, warfarin, heparin is less hazardous for the fetus, but risk of maternal thromboembolic complications is increased. So again, both would have pros and cons. Okay. So which would you choose? Okay. We will see later how to choose between warfarin and heparin. Following vaginal delivery, your anticoagulant therapy with warfarin or heparin may be restarted 6 hours later. Of course, before delivery, you have to make sure that you have stopped your warfarin or heparin. Warfarin because your fetal liver at least 2 weeks. But you have to stop either because, of course, if you don't stop it early enough, it would induce hemorrhage in your patient because it's an anticoagulant. Your bleeding will not stop. And following cesarean delivery, full coagulation is recommended. Resuming your unfractionated heparin or your low molecular weight heparin 6 to 12 hours after cesarean delivery. And with breastfeeding, it's not an issue because all of it, warfarin or any heparin formulation would be compatible with breastfeeding. Okay. So what if your cardiac lesion was detected during pregnancy? Can you do cardiac surgery? Although usually postponed until after delivery, you could do valve replacement or other cardiac surgery if you deem it necessary to be life-saving. Surgery can be elective when possible, and we have to maintain pump flow rate more than 2.5 liters per minute per meter squared. Perfusion pressure should exceed 70 millimeter mercury, and hematocrit should be kept more than 28%. So, generally postponed until after delivery unless your procedure would be life-saving. If you have had a heart transplant, could you get pregnant? So, do not discourage pregnancy if your heart transplant patient is stable. For more than a year post-transplant. Okay. So, valvular heart disease. So, this is the chief cause of serious mitral valvular disease in women of childbearing age in the non-industrialized world. So, in the developing countries, valvular heart disease would be cause of valvular disease in women of pregnancy age. Okay, so this would be a table that would be listing your major cardiac valve disorders, the type, the cause, the pathophysiology, and what it does to pregnancy. Okay? So your mitral stenosis will bring about heart failure because it would have fluid overload or tachycardia. Okay? Mitral insufficiency would more affect your ventricular function. Aortic stenosis would have your life-threatening because you have decreased preload. If you have your hemorrhage, if you have your regional analgesia. Aortic insufficiency also affects ventricular function and your pulmonary stenosis. So associated with right heart failure and atrial arrhythmias. Okay? So take note of this table. Okay, so that would be valvular heart disease. We also look at congenital heart disease. So your 90% with congenital heart disease survive up to childbearing age. And it is now the most common type of heart disease. So you have your AST, you have your VST, ventricular defects, and your patent ductus arteriosus. Okay. So it's either a cyanotic heart disease. So it develops when your heart lesions produce your right to left shunting of blood. Okay, most encountered lesion that would be cyanotic would be your tetralogy of Fallot. So this is characterized by, what's the tetralogy? Your large VST, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta. Okay. So, pregnancy after surgical repair of this congenital heart disease would be promising. So, both would be associated with good outcomes, transposition of the great vessels, and a single functional ventricle once corrected. Okay. What we don't want to occur would be your Eisenmengerization. So this is your pulmonary hypertension secondary to anything that arises from any cardiac lesion. And most common underlying defects that would cause your Eisenmenger syndrome would be your AST, your VSD, and your persistent ductus arteriosus. So what happens when your pulmonary vascular resistance exceeds your systemic resistance and would eventually lead to concomitant right to left shunting? And this is an absolute contraindication to pregnancy. Think pulmonary hypertension, which is a WHO risk assessment for. Okay, what then is pulmonary hypertension and why are we very much afraid of this scenario? Okay. In non-pregnant individuals, your pulmonary hypertensive patients would have a resting mean pulmonary pressure of more than 25 millimeter mercury. So that stiff pulmonary vasculature does not allow the normal fall in vascular resistance. And in pregnancy, that is very much affected. Okay. Normally, the increased cardiac output would lead to further pulmonary artery pressure elevation and then eventually push the patient to right-sided heart failure. With failure, the interventricular septum bulges leftward to impair your left ventricular diastolic filling, which comprises your cardiac output. Okay. And this would be your classification of your pulmonary hypertension of the European Society of Cardiology. Okay. Your pulmonary arterial hypertension could be idiopathic, could be hereditary, drug or toxin induced, or associated with connective tissue, HIV, portal hypertension, congenital heart disease, and schistosomiasis. Okay. Or you have your pulmonary hypertension due to left heart disease. So this is either your left ventricular systolic or diastolic dysfunction, valvular disease, congenital acquired left heart inflow-outflow tract obstruction and congenital cardiomyopathies, and congenital acquired pulmonary vein stenosis. Okay. Or pulmonary hypertension which is due to lung diseases or hypoxia. So these are your lung causes, either your COPD, lung interstitial disease, other restrictive and obstructive pattern, sleep disoriented breathing, alveolar hypoventilation, chronic exposure to high altitude, and developmental lung disease. Okay. And fourth would be your chronic thromboembolic pulmonary hypertension and other pulmonary artery obstructions, examples of which would be your chronic thrombotic pulmonary hypertension and your other artery obstructions such as tumors, arteritis, pulmonary stenosis, and parasites. Okay. And lastly, your pulmonary hypertension with clear and or multifactorial mechanisms. So there could be hematologic disorders, systemic disorders, metabolic disorders, and other fibrosing mediastinitis. Okay? So knowing all these conditions, how do we diagnose? Okay? So that we could avoid right heart failure and death. So pregnancy is contraindicated with severe disease, and this is especially true in women with pulmonary arterial changes. So they develop in most group 1 cases, milder cases from other cases. Group 2 being the most common, the prognosis of which is better. Okay, what's the management? So we should limit activity, avoid supine position, use diuretics, use supplemental oxygen, and use pulmonary vasodilators. Okay. So that is congenital heart disease. Okay. For cardiomyopathies, so these are solely or predominantly confined to the heart muscle. So some example, hypertrophic, dilated, peripartum cardiomyopathy. Secondary cardiomyopathies result from generalized systemic disorders. So that produce pathologic myocardial involvement. So this could be your diabetes, hypertension, thyroid disorder, SLE, and the like. Okay. So hypertrophic cardiomyopathy caused by mutations in genes that encode cardiac sarcomere proteins. And diagnosis is established by echocardiographic identification of a hypertrophied and non-dilated left ventricle in the absence of other cardiovascular conditions. And in this case, using general anesthesia would be the safest. For dilated cardiomyopathy, so there's left and right ventricular enlargement and reduced systolic function in the absence of coronary, valvular, congenital, or systematic disease known to cause myocardial dysfunction. Okay. And peripartum cardiomyopathy shares a genetic predisposition with both familial and sporadic idiopathic dilated cardiomyopathy. Okay. Cardiac failure develops in the last month of pregnancy or within 5 months postpartum. There's no identifiable cause for the cardiac failure, and there's no recognizable heart disease prior to the last month of pregnancy. So left ventricular systolic dysfunction would be the most demonstrated echocardiographic criteria. So it may be depressed ejection fraction or fractional shortening with a dilated left ventricle. Okay. Some would recover baseline, about half, within 6 months of delivery. So there are other cardiomyopathies. So there's arrhythmogenic right ventricular dysplasia. Okay, so this is progressive replacement of your right ventricular myocardium with adipose and fibrous tissue. Least common would be a restrictive cardiomyopathy. So this is characterized by ventricular filling pattern, which makes your myocardial pressure stiff, which increases your ventricular pressure. And more rare would be your Takotsubo cardiomyopathy. So this is an acute reversible left ventricle apical wall ballooning. Okay. We should be on the lookout for infective endocarditis. So this would be persons at greatest risk for endocarditis are those with congenital heart lesions people with IV drug use history, people with degenerative valve disease, and intracardiac devices. Okay. So whenever you look at your infective endocarditis diagnosis, remember your Duke's criteria. Okay, you've had this in your cardiology. So you have your major and your minor criteria. So you have 2 major or 1 major and 3 minor or 5 minor criteria. Okay? Or you have your pathologic lesions and your microorganism. Okay? Part of your major criteria would be your typical microorganisms consistent with infective endocarditis from 2 separate blood cultures, persistently positive blood culture, or a single positive blood culture for Klebsiella burnetii or phase 1 IgG antibody, or evidence of endocardial involvement is to the echo positive for IE or a new valvular regurgitation. Minor criteria would be predisposition, fever more than 38 degrees, vascular phenomena, immunologic phenomena, and on microscopy, okay, or serologic evidence of active infection with organism consistent with IE. Okay. So, recommends prophylaxis for dental procedures in those with prosthetic valve or prosthetic material used in a valve repair, prior endocarditis, unrepaired cyanotic heart defect or repaired lesion with residual defect at prosthetic sites, and valvulopathy after heart transplantation. Okay. So this would be your prophylaxis for infective endocarditis in high-risk patients. So it is not for all, only in high-risk patients. So you could give either your ampicillin 2 grams or ceftriaxone or ceftriaxone 1 gram. If allergic to penicillin, you could use your cefalozin or ceftriaxone, or your clindamycin. Oral would be your amoxicillin 2 grams. If you will follow the American Heart Association, you use your amoxicillin 2 grams or ampicillin 2 grams IV. If allergic to penicillin, clarithromycin, fibromycin, cephalexin, clindamycin, or cefazolin or ceftriaxone. Okay. Diseases of the aorta. So there's Marfan syndrome. So Marfan syndrome and coarctation are 2 aortic diseases that place the pregnant women at greater risk for aortic dissection. Remember, your Marfan syndrome and your coarctation are at least a WHO 3 or 4 regardless of status. So you do aortic angiography to diagnose aortic dissection or disease. Okay. What is Marfan syndrome? So this is an autosomal dominant connective tissue disorder and is without racial or ethnic predilection. So what happens? There's generalized tissue weakness that results in cardiovascular complications. In the pregnancy, if you know that you have a thoracic aortic root or ascending aortic dilatation, monthly or bi-monthly echo measurements of the ascending aortic dimensions are recommended to detect expansion. and we use beta-blocking agents for treatment. That's dissection. For a coarctation, aorta is abnormally narrowed and is accompanied by abnormalities of your other large arteries. So major complications of which would include congestive heart failure after long-standing severe hypertension, infective endocarditis, most particularly your bicuspid aortic valve, and aortic rupture. We use our beta blockers because it worsens in pregnancy. Okay. Ischemic heart disease could also occur. So because of lifestyle, there are more pregnant women getting pregnant with coronary artery disease. Okay, usually we have a strong history of family history, diabetes, smoking, hypertension, hyperlipidemia, and obesity. Okay. So it can result from coronary arteriosclerosis, dissection, embolism, or arteritis, your acute coronary syndrome. But for diagnosis, it does not differ from non-pregnant patients and it's based on clinical presentation. Okay, so it's progressive. So ischemic heart disease is associated with hypertension or diabetes. Pregnancy in most of these women who have already had a prior ischemic heart disease is inadvisable. Oops. I think that's the last slide. So that is for cardiopulmonary, cardiological diseases in pregnancy. Any questions so far? Let's have our pulmonary disease. Any questions for cardiac disease in pregnancy? So if there's none, let's proceed. Okay. Pulmonary disease in pregnancy, especially with the onset of your coronavirus for the past 3 years, has changed drastically how we manage pulmonary disease. Okay. What used to be just a simple cough and cold may mean something else. Okay. Prior, it was asthma and community-acquired pneumonia, which accounted for almost 10% of non-obstetrical antepartum hospitalizations. And most likely, with the influx of your coronavirus for the past 3 years, these statistics would most definitely change in the long run. Okay. What's important to note is that pregnant patients tolerate lung disease poorly because of, again, physiologic changes in the ventilatory physiology that renders the adjustment of our respiratory capacities to change, to adapt, to have limited adaptation. Okay, and then always, again, we start with your normal pulmonary physiology. So what is normal? So vital capacity increases by approximately 20% by late pregnancy. Your expiratory reserve volume declines from 1,300 ml to 1,100 ml. Okay. There's progesterone-driven respiratory stimulation, and this in turn raises your tidal volume by as much as 40%. And your minute ventilation increases 30 to 40% due to higher tidal volume. So as a result, your arterial partial pressure of oxygen rises from 100 to 105 millimeter mercury. Okay, what else? So your expanded metabolic demands cause a 30% increase in carbon dioxide production. But it has a greater diffusion capacity and hyperventilation. Your arterial carbon dioxide is reduced from 40 to 32 millimeter mercury. Residual volume diminishes by 20%. And an expanding uterus and intra-abdominal pressure would lower your chest wall compliance by a third. And what it does would reduce your functional residual capacity by 10 to 20%. So the sum of your expiratory reserve and residual volume, so that is your functional residual capacity. Okay. So how does it play in the pathophysiology of your respiratory diseases in pregnancy? Okay. Most common would be your asthma. So it's, as you know, in medicine, it's a chronic inflammatory airway syndrome, a reversible airway obstruction of your bronchial smooth muscle contraction, caused by congestion, caused by mucus and mucosal edema. Okay. And the clinical course would vary from just a mild wheezing to just a chronic cough to severe bronchoconstriction, which in the end would obstruct airway, decrease airflow. Okay. And would further lower your forced expiratory volume and forced vital capacity ratio and your peak expiratory flow rate. Okay. So in effect, your work of breathing would increase and therefore produce your chest tightness, chest wheezing, breathlessness, because there's ventilation, perfusion mismatching. Okay. And of course, this is the classification of your asthma severity from intermittent, mild, moderate, and severe, depending on how many times you feel the symptoms, how many times you awake at night, if you need a short-acting beta agonist to control your symptoms, if it interferes with your normal activity, and more objective would be assessment of lung function using your forced expiratory volume and your forced expiratory volume over forced vital capacity. So, in the non-pregnant, it's reversible and well tolerated. Okay, in the pregnant, we are more susceptible to your asthma changes because of, remember, we have your diminished functional residual capacity and a greater pulmonary shunting. So if it continues, it would start with a mild respiratory alkalosis, which affects your functional expiratory volume, but still have a normal arterial oxygen. Your carbon dioxide is decreased. Eventually, it will turn into respiratory alkalosis, affecting your forced expiratory volume more, start to affect your arterial oxygen, your arterial carbon dioxide is decreased. leading to ventilatory failure. Then you enter your danger zone, which turns your arterial carbon dioxide to normal, and respiratory failure, leading you to acidosis and to your high arterial carbon dioxide. Okay. Affects 8% of gravidas, and always remember the 1/3 rule. 1/3 will worsen, 1/3 remain unchanged, and 1/3 will improve. So, outcome. Of course, the outcome worsens markedly with status asthmaticus. Okay? And these are the maternal and perinatal outcomes in women with asthma. So there would be a higher odds ratio to have hemorrhage, GDM, chorioamnionitis, preeclampsia, abruptio, previa, ICU admission, and pulmoembo. Perinatal, higher odds ratio to have smaller babies, to deliver preterm and pre-labor rupture of membranes, and to have congenital anomalies. Okay. The effect on the fetus, because the fetal response to maternal hypoxemia would be to lower umbilical blood flow, higher systemic and pulmonary vascular resistance, and decreased cardiac output, which thereby produce your fetal growth restriction. And of course, you have to be careful in the administration of drugs because of the teratogenic effect of drugs used in asthma, which we'll see later. Okay. We evaluate by doing your pulmonary function test. So sequentially measure your forced expiratory volume 1 or your pulmonary expiratory flow rate to measure severity. Okay. For the management of chronic asthma, okay, awareness or patient education about general asthma management and its effect on pregnancy. Okay, you always have to tell your patient if you are out of breath, more so the baby that is inside you. So you have to avoid your triggers. So that's number 2. Avoid or control precipitating environmental factors. If you get asthma when it's hot or when it's cold, avoid it. When it's dusty, avoid it. Most commonly, viral infections are frequent triggers. So that protect yourself, vaccinate yourself from influenza and pneumococcal vaccination if you are an asthmatic patient. Okay. Do an objective assessment of your pulmonary function with your PEFR or forced expiratory volume, and check the fetal status with your serial growth ultrasound and antepartum testing. Okay? Do your pharmacological therapy so that you have control and treat exacerbations. You have to review the medication so that you can avoid non-compliance. Okay. Treatment of related disorders, for example, avoid smoking, depression, rhinitis, and gastroesophageal reflux is imperative. Okay. So this would be a table of your recommended therapy. If it's mild intermittent, short-acting beta agonist for any symptom. If it's mild persistent, you add your low-dose intracortical steroids, inhaled steroids. If it's moderate persistent, you add your long-acting beta agonist. Severe persistent, you use your high-dose inhaled corticosteroids and your long-acting beta agonist. And if it's a very severe persistent, you use your oral corticosteroids for management. So you have your inhaled corticosteroids. You can use your theophylline. You can use your anti-leukotrienes for management of chronic asthma. Okay. So if it's acute, you have the same as the non-pregnant patient, but you have lower thresholds. You give your IV hydration, you give your supplemental oxygen to make sure that you maintain your oxygen arterial pressure 60 millimeter mercury, preferably normal, along with at least 90 to 95% oxygen saturation. So do your pulmonary function tests. You do nebulize for 3 doses. If you repeat, if it's more than 70%, you can discharge the patient. If it's less than 70%, admit to the acute care unit. Okay? And you may give your methylprednisolone. That's your IV steroids, your inhalant albuterol and ipratropium, your inhaled corticosteroid, serial PFTs, and you could add your leukotriene in Montelukast. Okay. So these are your weapons, your short-acting beta-adrenergic agonist. You use your systemic corticosteroids, IV magnesium sulfate, or theophylline. Of course, what you want to avoid would be your status asthmaticus or your respiratory failure. So this is severe asthma not responding to therapy for more than 30 to 60 minutes. Consider your early intubation so that we could avoid respiratory fatigue, avoid carbon dioxide retention, and hypoxemia. You could also use your ECMO. Okay. In labor, what should we do? So your PEFR or your forced expiratory volume 1 should be determined. Okay. You can use your oxytocin or your prostaglandins for cervical ripening and induction. So it's important to use a non-histamine releasing narcotic. You also have your epidural analgesia. Conduction analgesia is also preferred because tracheal intubation can trigger severe bronchospasm. Okay. Postpartum hemorrhage is treated with oxytocin or prostaglandin or E2. You cannot give your metergine or methyl-orgometrin maleate to your patients. Okay? Prostaglandin F2 alpha is also contraindicated because it may cause significant bronchospasm. Okay, that's for asthma. Okay, there's also a condition called acute bronchitis. So this is an infection of the large airway manifested by cough without your pneumonitis. So usual isolates would be your influenza A and B, parainfluenza, RSV, coronavirus, adenovirus, and rhinovirus. Okay. But this usually lasts for 10 to 20 days and occasionally lasts for a month or longer. So it's just supportive care. Suppress the cough. Okay. Some expectorants with guaifenesin appear safe in pregnancy. Of course, we don't want it to develop into pneumonia, and it's one of the leading causes of death in pregnancy in the United States. So, community-acquired pneumonia. So, the offending pathogen is often not identified, although these percentages changed in 2020 due to the COVID-19 pandemic. Before, half of bacterial isolates were Streptococcus pneumoniae. Okay, that was according to Williams. But most likely when the new studies, you will see how it will change. And this accounts for 4.2% of antepartum admissions for non-obstetric complications. So, pneumonia is also a frequent indication for postpartum readmission. Okay. So, there's loss of ventilatory capacity, and that is less well tolerated in the pregnant women. Of course, your fetus cannot accommodate or tolerate hypoxemia and acidosis. And of course, any infection would stimulate preterm labor and may cause premature rupture of your membranes. So, such that any gravida suspected of having pneumonia should undergo chest radiography, albeit with an abdominal shield, so as to reduce radiation exposure. Okay. So, risk factors of bacterial pneumonia. You have your cigarette smoking, chronic bronchitis, asthma, binge drinking, and your HIV. Okay. It will present as a cough, dyspnea, productive sputum, chest pain, which is pleuritic. So it could be mild symptoms and malaise precede your mild leukocytosis. Okay? Diagnosis would not be routinely recommended, such as using sputum cultures, PCR tests, cold identification, not routinely recommended, except for, of course, if you're looking at COVID-19 or influenza A and B. Okay? So you only test PCR or do a nasal swab if you are considering influenza A and B, COVID-19. Okay. Because outpatient therapy could be done, 24-hour observation with optimal follow-up are reasonable options. Okay. And we have to be careful because severe pneumonia is a relatively common cause of your acute respiratory distress syndrome. So these are risk factors to know if your community-acquired pneumonia would be at risk for early deterioration. Of course, your RR is more than 30, O2 sats less than 90, hypothermia less than 36, hypotension that needs aggressive fluid resuscitation, multilobular infiltrates, leukopenia, thrombocytopenia, and there's confusion and disorientation. Okay. Why don't you need to diagnose unless it's COVID-19 or influenza A or B? Because it's often empirical, the treatment. So monotherapy initially is done with a macrolide. Okay. During influenza season, we routinely administer oseltamivir along with empirical therapy for bacterial pneumonia. Okay. Teratogenicity risk of fluoroquinolones is low, and these should be given if indicated, although it is contraindicated in pregnancy. If MRSA is suspected, you use your IV vancomycin, 15 milligram per kilogram every 12 hours, or your linezolid, 600 milligram every 12 hours. Okay, improvements usually evident within 48 to 72 hours. And you could shift to oral medications if your fever resolves in 2 to 4 days. Treatment of uncomplicated pneumonia is recommended for 5 to 7 days. And before you discharge or before you discontinue therapy, you should be afebrile for 48 to 72 hours and demonstrate signs of clinical stability. Okay. Your chest x-ray may not be normal up to 6 weeks for the pneumonia to be completely resolved. And serial radiography is only recommended if your fever is persistent. And you have to be at the lookout because 20% will develop pleural effusion. How will it affect pregnancy? Of course, you have to watch out for prematurely ruptured membranes and preterm delivery because of the infection. Look out for low birth weight neonates and look out for preeclampsia and the increase of cesarean delivery. Of course, to prevent, you do your pneumococcal vaccine. Okay. As mentioned, for influenza pneumonia A or B, you have to do your PCR or you have to do your nasal swab. So these are caused by RNA viruses that cause potentially epidemic respiratory infection, which includes your pneumonitis. So transmission is through aerosol. So it infects your columnar epithelium, which is ciliated, alveolar cells, your mucous gland cells, and macrophages. How does it present? This usually presents faster 1 to 4 days after the exposure and would also present with your fever, cough, myalgia, and chills. Pneumonia is the most frequent complication, and risk factors would include advanced pregnancy, smoking, and chronic hypertension. So this is 12% of pregnancy-related deaths, and ECMO may be life-saving. As mentioned, you just do your rapid PCR testing and nasal swab for your influ A and B. So usually this is characterized by sparse sputum production, and in radiography, it's your interstitial infiltrates. And then secondary or mixed pneumonia. So there's a bacterial superinfection by your strep or your staph after 2 days of your initial clinical improvement. So you do your supportive treatment for uncomplicated influenza and early antiviral therapy. Okay, so you treat all pregnant women with suspected or proven influenza, and you do this with your oseltamivir 75 milligrams BID. Okay, that would be your neuraminidase inhibitor. Okay, mechanism of which would be your interference with the release of the virus from your infected host cells and thus preventing infection of the new cells. Of course, prevention would be important as well. Vaccinate against influenza is, of course, recommended. Okay. We've talked about a lot about coronavirus, and that's it. This is something that you should know at the back of your hand. So you have your atypical pneumonitis with a case fatality rate of approximately 10%. Okay. In pregnancy, SARS in pregnancy had a case fatality rate of up to 40%. So for coronavirus per se, there's no published yet. So, of course, it would produce your abnormal intervillous or subchorionic fibrin deposition, would produce your extensive fetal thrombotic vasculopathy. And it would range from your mild common symptoms to severe pneumonia to your ARDS, as you have known. And so far, what we've seen, common complication would be like in infections, preterm labor. So you have to care for the affected patient in a negative pressure airborne infection isolation room and follow COVID protocols. We don't know really if it's a vertical transmission or because the baby is within the same area as the mother or the infected patient. That's why there's transmission. But again, we still have to be careful and more studies have to be done to look at coronavirus and how it affects pregnancy. Studies are ongoing. Maybe in the next Williams edition, this would have a more substantial part in the chapter. Okay. Next would be varicella pneumonia. So infection with varicella zoster virus would be the same agent responsible for chickenpox. So this results in pneumonitis in 5% of gravidas. Say, more rare also would be your pneumocystis pneumonia. So this is your formerly pneumocystis carinii. So it's now pneumocystis jirovecii. So this is also an interstitial pneumonia characterized by dry cough, tachypnea, dyspnea, and diffuse radiographic infiltrates. So your pneumocystis pneumonia was the most frequent HIV-related disorder in pregnant women. So it's an opportunistic infection. So you treat with trimethoprim sulfamethoxazole for 14 to 21 days or orally for prophylaxis. You could also have fungal pneumonia. So also characterized by cough and fever caused by your histoplasmosis and blastomycosis. So women with associated erythema nodosum have a better prognosis, whereas mediastinal lymphadenopathy may more likely reflect disseminated disease. In most cases of your cryptococcosis in pregnancy manifest as meningitis. Treatment would be amphotericin B or ketoconazole. Okay. So we're done with pneumonia. So we've had asthma, acute bronchitis, and your pneumonia conditions. Of course, in India and Philippines, when we talk of respiratory disease, we cannot not talk about your tuberculosis. This is caused by your Mycobacterium tuberculosis, which is a cough with minimal sputum production, accompanied with low-grade fever, hemoptysis, and weight loss. So chest X-ray picture would be your cavitation or your mediastinal lymphadenopathy. Diagnosis would be your stain smears of your sputum, which would reveal your acid-fast bacilli. There are other forms of extrapulmonary tuberculosis, which include your lymphadenitis, pleural, genitourinary, skeletal, meningeal, gastrointestinal, and miliary or disseminated tuberculosis. Your endometrial tuberculosis, we do not want because it can cause tubal infertility. But when you do get pregnant, okay, it is related to 7.1 cases per 100,000 of your pregnancy-related hospitalizations. And your extrapulmonary TB is less common. Okay. Adverse maternal and perinatal outcomes. For maternal, you do your CS, acute respiratory disease, anemia, pneumonia, miscarriage, prenatal admission. For the baby, you look at preterm birth, low birth weight, anomalies, fetal distress, and mortality. To diagnose, we do your tuberculin skin test. So this is your PPD of intermediate strength of 5 tuberculin units. Okay. So if it's more than 5 in diameter and requires evaluation for active disease, which will include a chest radiograph. Okay. Sometimes it's an ongoing banter among medical personnel. Oh, I have PPD and the contest is who has the higher tuberculin skin test. How big would be the skin test? Oh, I have PPD and it's 10 millimeters or sometimes it's 20. So, but then again, that's taking things at a grain of salt because you have to protect yourself also. You could also use your interferon gamma release assays. So these are blood tests that measure interferon gamma release in response to antigens that are present in M. tuberculosis, but not in your BCG. Or directly observe therapy to ensure regimen compliance when you do have your diagnosis. Treatment. For latent, it is recommended that isoniazid therapy be delayed until after delivery. Okay. Some even recommend withholding treatment until 3 to 6 months after delivery because of increased isoniazid-induced hepatitis risk in postpartum women. So, of course, you have to measure your hepatic transaminases with isoniazid therapy. Except when you have your recent skin test converters are treated antepartum because active infection is 5% in the first year. Okay. Or skin test positive women who are known to have exposure to active infection. Or women with HIV infection. So in these cases, you do not delay treatment. Okay. For active infection, first 2 months, bactericidal phase, you give your isoniazid, rifampin, and ethambutol. 7-month continuation phase with isoniazid and rifampin. Okay? If you notice the treatment, there's a tuberculosis drug that's missing from the regimen. And we do not give streptomycin because it's a teratogenic drug and causes your congenital defects in your fetus. Breastfeeding is not prohibited during TB therapy. And your second-line regimens, as I've mentioned, streptomycin, aminoglycosides, and the rest are ototoxic to the fetus and are contraindicated. Tuberculosis with HIV. So you begin concomitant therapy with your anti-tuberculosis and your antiretroviral therapy, which may cause immune reconstitution inflammatory syndrome or your IRIS with toxic drug effects. So what we do, we begin your antiretroviral therapy 2 to 4 weeks after your anti-TB therapy. Okay. Rifampin or rifabutin may be contraindicated if you are using protease inhibitors or your non-nucleoside reverse transcriptase inhibitors. Okay, if there's resistance to rifampin or rifabutin, you use your pyrazinamide. How do you prevent transmission? So you see your level 4 protection has been present for the longest time, and it is because of tuberculosis. Airborne precautions should be initiated for any patient with active pulmonary TB who remain infectious despite treatment. Use a negative pressure room. Surgical masks during interactions recommended at least an N95. Okay? N95 for the healthcare workers. Okay. You only consider non-infectious after the patient has completed 2 weeks of directly observed treatment compliance, after 3 consecutive AFP negative sputum smears, or after clinical improvement evidenced by absent fever and resolving cough. Okay. Only now are we taking the personal protective equipment seriously and protective precautions, because compared to tuberculosis, coronavirus has a more acute onset and a higher case fatality rate short term. Okay. Neonatally, tuberculosis bacillia can also infect the placenta, but the fetus infrequently becomes infected. Okay. Congenital tuberculosis applies also to newborns who are infected by aspiration of infected secretions at delivery. So you look at hepatosplenomegaly, respiratory distress, fever, and lymphadenopathy. So if the mother is infectious, you give 3 to 6 months of isoniazid prophylaxis to the newborn. Some rarer conditions would be your sarcoidosis. So sarcoidosis is a chronic multisystem inflammatory disease of unknown etiology. So this is characterized by an accumulation of T helper lymphocytes and phagocytes within non-cacheating granulomas. This is genetic and would involve the pulmonary system most commonly, followed by your other organ systems. So the hallmark of pulmonary involvement would be interstitial pneumonitis. So lymphadenopathy, especially of the mediastinum, is present in 75 to 90% of cases. A third each would have uveitis and skin involvement. So this is your erythema nodosum. Diagnosis of which would be biopsy, and the prognosis is good and usually results without treatment in half of the patients. What we use for treatment would be glucocorticoids. Okay. Therapy is usually withheld for a several-month observation period. Only when your inflammation does not subside will you use prednisone, 20 to 40 milligrams, given daily and tapered to. For those with an inadequate response, immunosuppressive or cytotoxic agents and cytokine modulators can be used. Okay. So since it's uncommon and frequently benign in pregnancy, okay, meningitis, heart failure, and sarcoidosis complicating pregnancy have been described. So these are mentioned: preeclampsia, preterm delivery, DVT, eclampsia, and pulmonary embolism. And it's treated the same way as you treat the non-gravid woman. Okay. Another condition would be your cystic fibrosis. So it's an autosomal recessive exocrinology and is one of the most common fatal genetic disorders in Caucasians. Okay. So there are more than 2,000 mutations in a 230 gene on the long arm of your chromosome 7. Okay. The normal peptide gene product functions as a chloride channel and is termed the cystic fibrosis transmembrane conductance regulator. Okay. If there are mutations in this chloride channel, it alters your epithelial transport of electrolytes in CFTR secretory cells. So your exocrine glands would eventually develop a ductal obstruction from these thick viscid secretions. Okay. And your sweat gland abnormalities would be the basis for doing your sweat test in your cystic fibrosis and would show elevated sodium, potassium, and your chloride levels in your sweat. So it usually involves the lung and would have bronchial gland hypertrophy with mucus plugging and small airway obstruction, which would lead to subsequent infection that ultimately causes chronic bronchitis and bronchiectasis. So what happens would be extensive fibrosis, airway obstruction with your VP mismatch developing. And this would result to pulmonary insufficiency. Okay? Usually they are subfertile because of even your cervical mucus becomes thick and mucus-like. So there's in-depth preconceptional counseling. Males who have cystic fibrosis would have oligo or aspermia due to the congenital bilateral absence of the vas. 98% are infertile. But 4% of women can become pregnant every year. And what you could do your intrauterine insemination or your in vitro fertilization in these affected women. Long-term prognosis for the parents and mutation transmission to their offspring, of course, would affect their offspring. Such that ACOG recommends screening to offer to all women affected by fibrosis who are currently pregnant or considering conception. And it is one of the conditions that it is included in your newborn screening programs. Okay, how do we care for the pregnant patient with cystic fibrosis? So, pregnancy outcome is inversely related to severity of lung dysfunction. So, if it's advanced, chronic lung disease, hypoxia, frequent infections, and it may prove deleterious to the pregnant patient. Pancreatic dysfunction may cause malnutrition, and 10% may have concomitant pregestational diabetes. Cystic fibrosis is not affected by pregnancy, its natural course of disease. How do we manage? We do close surveillance for development of superimposed infection, the development of diabetes, and heart failure. We look at your serial pulmonary function test to assist management, to estimate prognosis. So emphasis is placed on postural drainage, bronchodilator therapy, and infection control. Beta-adrenergic bronchodilators could help obstruction and constriction. Inhaled recombinant human deoxyribonuclease improves lung function by reducing your sputum viscosity, and calcium and vitamin D are given for poor bone mineralization. If there's pancreatic insufficiency, it's supposed to be replaced with your oral pancreatic enzymes. And of course, if you have infection due to cough and mucus production, use your penicillin or cephalosporin or your tobramycin and colistin. Okay. There are poor and maternal and perinatal outcomes in affected women if ever they do get pregnant, and is quantified by pulmonary function studies. And these are the odds ratios for maternal complications in women with cystic fibrosis. So how you have your asthma, thrombophilia, diabetes, acute kidney injury, respiratory failure, down the line, mechanical ventilation, pneumonia, and death. Okay. If you have had a lung transplant, cystic fibrosis could lead to lung transplant, and of course, maternal outcomes would be less favorable in these patients. Okay. And last condition would be your carbon monoxide post-poisoning, most common frequent cause of poisoning worldwide. So it's odorless and tasteless, and it's problematic because it has a high affinity for hemoglobin binding. It displaces your oxygen, hinders its transfer, and results in hypoxia. And death and anoxic encephalopathy cognitive defects develop. So what happens? Through several alterations, the rate of carbon monoxide production almost doubles in normal pregnancy because of the adaptations in your pulmonary ventilatory functions. So, maternal symptoms usually appear when your carboxyhemoglobin concentration is 5 to 20%. So, what are the symptoms? You have your headache, have your weakness, dizziness, etc. And because your fetal hemoglobin has a higher affinity for carbon monoxide, your fetal carboxyhemoglobin levels are 10 to 15% higher than those in the mother. And what's more important, half-life of carboxyhemoglobin is 2 hours in the mother, but 7 hours in the fetus. And you will see just by this analogy how it is more problematic for the fetus than the mother when carbon monoxide poisoning would occur. Treatment would be supportive. You have to administer oxygen immediately. Hyperbaric oxygen is generally recommended if carbon monoxide exposure has been significant. Or some have recommended that if maternal levels exceed 50 to 20%, then you do hyperbaric oxygen therapy. And that would be your pulmonary diseases in pregnancy. Any questions for this afternoon?